Well, everything is good.
Hello,
Yes,
I'm
here.
Geir Ogrim from Norway. I'm a neuropsychologist working in the neuropsychiatric team in Ostfold Hospital Trust, Norway, and also affiliated to the Gilberg Neuropsychiatry Center in Sweden. Thanks for the organizer for inviting me. I will talk about biomarker support for ADHD diagnosis based on event-related potentials and scores from an attention task. The research that I will be talking about was published this spring in Psychiatry Research. I will briefly mention the diagnostic criteria for ADHD as we see them in DSM-5. The symptoms are observed before age 12 years. Statistically deviant and impairing symptoms of inattention, hyperactivity, and impulsivity. At least 6 of 9 symptoms of inattention and 6 of 9 symptoms of hyperactivity, impulsivity have to be present. And we have the inattentive subtypes with the symptoms of inattention present but not hyperactivity, impulsivity. The symptoms are seen for at least 6 months and in different settings like school and home, and they lead to impairment in home, school, and social settings, and symptoms are not better explained by another diagnosis. This may be an example of what some people think about ADHD. This is perhaps another example, and a third example. Backdrop: the need for biomarkers. As you know, diagnoses in psychiatry are based on observed symptoms, developmental history, somatic and psychiatric differential diagnosis, and there is much subjectivity involved from the informant and from the clinician. And ADHD and other neuropsychiatric disorders, they are seen as brain-based disorders, but no brain-based methods are needed to put forward the diagnosis. So more objective measures closer to brain function than observed behavior are needed to improve diagnostic procedures and eventually treatment. A few words about the ADHD controversy. The etiologies of ADHD symptoms may differ from person to person. Let's take, for example, inattention. It may be related to problems with vision, with hearing, with food intake, with sleep, with language, with learning disabilities, with trauma, chronic worrying about bullying, family conflicts, and so on. So it may be say it's overdiagnosed, perhaps underdiagnosed, or both. And there are great variations in the prevalence of ADHD between clinics, districts, and countries, and this may be related partly to the interpretation of the diagnostic criteria. Without going into details about biomarkers, I just read the red text here. Biomarkers can provide an objective basis for diagnosis, treatment selection, and outcome measures. And what is said here about endophenotypes, I will not go into now. You can read it by yourself. Let me underscore that I don't think that the behavioral criteria for ADHD should be related, but there is a need for supplementary biomarkers. And for biomarkers to be of clinical use, the retest reliability has to be proved, and the first step is exploring how well the biological marker discriminates between a diagnostic category and healthy controls. And the second step, how it discriminates between diagnosis with overlapping symptoms. But it would be naive to believe that a single biological marker can be specific for a single diagnostic category. It's more likely that the tested parameter identifies a certain subgroup covered by several diagnostic criteria. For example, inattention, that could be part of several diagnoses. This figure may illustrate the relation between diagnostic scale, disorder scale, the Gaussian curve pointing to the left. You see the red line, which indicates the cutoff for pathology, and you have the hypothetical scale, the biomarker scale, the Gaussian curve pointing downwards, and the blue line is the cutoff for pathology. This gives us 4 groups. You have the green ones, they are in the normal range on both scales. You have the red ones, they are above the scales, both scales, so they are the real patients. But you have 2 extra groups of interest. You have the blue ones, they are below the cutoff on the traditional scale, but they are in the pathological range of the biomarker scale. These patients may be called patients at risk for the diagnosis. And you have the X's, they are above the threshold on the disorder scale, but they are in the normal range of the biomarker scale. Maybe these patients are just lookalikes and not real patients. A word about our test procedure. We register electrical brain activity, EEG. The focus is not on medical pathology, but the focus is on patterns indicating problems with, for example, attention, impulse control, etc. This is what our equipment looks like, although our patients are not as pale as this one. This is an example of 7 seconds of EEG registration from 19 sites. Examples of theta, alpha, and beta are highlighted. When we meet the youngsters, we tell them that there is no danger involved, there is no pain. We're only reading electrical activity and not putting something into their brains. And we do not read their minds. We want to see how the brain works when it is relaxed and when it concentrates, and we will compare the results with age-matched controls. The preparation for the registration takes about 5 to 10 minutes, and we register 3 minutes with eyes closed, 3 minutes with eyes opened, and a 20-minute task called VCPT with a couple of short breaks during the task. This picture illustrates the VCPT task. The pictures come in pairs, one first and then the other, and the pause before the next pair comes on. If the first picture is an animal and the second one is an animal, always the same animal, then they should press the button. If the first picture is an animal and the second a plant, do not press the button. And if there is the pairs is plant, do not press the button. And if the pair is plant, human, and some sounds, do not mind the sounds and do not press the button. It's only animal, press the button. The VCPT, which is a visual continuous performance test or a cued visual go-no-go task. It gives us electrophysiological data, but it also gives us traditional attentional variables such as omission errors, a measure of attention, commission errors, an indication of impulsivity, reaction time reflecting processing speed, and reaction time variability, a measure of attention. A very short explanation of event-related potentials, ERPs. Sensory and cognitive events or activity, called events, create small deflections in the EEG. By repeating the events a large number of times with a fixed time interval, for example 3 seconds, background EEG can be cancelled out and the event-related deflections stand out as an ERP component. Let's look at the example. An ERP component called P1 in patient M is the blue line, compared with norm, which is the red line. It's not shown here, but the significance level of the difference was very high. And so what is the functional meaning of this difference? Based on the literature, we can speculate that it represents sensory sensitivity or maybe a heightened stress or anxiety level. In our system, what are we looking for? Well, compared with norms, what happens when visual stimuli enter the occipital area? When visual stimuli are identified as targets, animals in our system. And when picture number 1 is an animal and preparation for pushing the button takes place. What happens when picture number 2 is an animal, the go condition, to push the button. What happens when picture number 2 is not an animal, the no-go condition, indicating template update, stop planned pushing, implement plan B, which is don't push, and what happens when unexpected sounds occur, the novelty component. This slide is about EEG-based biomarkers for ADHD, based on hypotheses from published research and clinical experience. Increased omission as errors and the reaction time variability in the task, excess theta in EEG spectra or a high theta-beta ratio, probably reflecting underactivation of certain parts of the central nervous system, reduced amplitude of ERP component QP3, which is identification of target, reduced amplitude of ERP component CNV, contingent negative variation, reflecting preparation of response, reduced amplitude of ERP component N2 no-go, reflecting template update or a new plan, and reduced amplitude of ERP component P3 no-go, which is allocation of attentional resources and inhibition. In our published study, we compared 61 ADHD patients with 69 controls, which were matched for age and sex, and the age span was 9 to 12 years, as you see. We found 9 variables that were significant difference between the two groups, with an effect size of Cohen's d 0.5 or higher. This was omission errors and commission errors and reaction time variability in the test. There were some ERP components, the P2 amplitude at site 02, not commented on here, the QP3, the CNV, the go amplitude, the no-go amplitude, and the N2 no-go amplitude. We computed a diagnostic index based on these 9 variables. How we did it is explained in the paper. The diagnostic index had an effect size of 1.47, which is a large effect size. What it means is illustrated in the figure to the left. You see the two means are 1.5 standard deviation apart, which is a large distance, but we also see there are overlapping parts of the curves, so we don't separate totally, of course. The diagnostic index, which was based on the healthy controls in the first study, was also applied to a new independent study with 20 ADHD patients and 21 typically developing children. 8 of the 9 variables differed significantly in the new sample, and the effect size was in fact 3.03. The 3 following slides show ERPs for ADHD and controls, typically developing children, in the main study called TEST and in the independent retest sample called retest. Slide 1 shows the Q condition, that is, picture 1 is an animal, and ERPs are seen at sites F set, P set, and C set. These sites are used in all 3 slides. On slide 2 is the go condition. Picture number 2 is an animal. Push the button. And slide 3 is the no-go condition. Picture 2 is not an animal. We see the N2 no-go component, template update, and the P3 no-go component, implementing a new plan. Don't push the button. This is the first slide, the Q condition, and you see at site P set at the bottom there is a significant difference between the 2 groups in both studies, even greater in the retest study. This slide shows the go condition, and we see at site P set there is a significant difference between the 2 groups in both studies. And this is the no-go condition. At F-set, you see the difference between the group on the N2 no-go component, and at site C-set, you see the difference between the group and the P3 no-go component. Before summing up with a couple of highlights, I will mention for you that the paper I refer to is open access. And the highlights. Diagnosing neuropsychiatric disorders like ADHD is often difficult and controversial, partly because criteria based on objective measures are missing. Internationally, there is an increasing focus on the need for clinically useful biomarkers. EEG-based biomarkers are excellent candidates as they are non-invasive, can be applied to children, and are affordable. In this study, we combined 9 variables, ERPs and test scores, into a diagnostic index discriminating between ADHD and healthy controls with a large effect size in 2 different samples. That was my presentation, so thank you for listening.
Yes, thanks a lot. It was very interesting, and for me it's very interesting, and thank you for sharing your results with us. It's a big future.